Next is Dr. Vinny Joy, free paper 53.
Good afternoon, everyone. My study is on visual acuity and retinal morphological changes following retinal detachment surgeries. So, retinal detachment, rhegmatogenous retinal detachment is the most common type of retinal detachment with an annual incidence of rate of 6.9 to 18.2 per 1 lakh person. It develops when there is a retinal break or full thickness defect in the neurosensory retina and the fluid ingresses into the subretinal space, resulting in separation of the neurosensory retina and the underlying RP. Rhegmatogenous retinal detachment is primarily treated with either scleral buckling, pars plana vitrectomy, pneumoretinopexy, or combined vitrectomy and scleral buckling. Intraocular gases are important in managing RRD with vitrectomy, as they allow closure of retinal breaks until a permanent chororetinal adhesion develops. Fundus autofluorescence, or FAF, is a retinal imaging modality used in clinical practice which is non-invasive to provide a density map of lipofusion, the predominant ocular fluorophore in the retinal pigment epithelium. And optical coherence tomography, or OCT, is also a non-invasive in vivo imaging modality that allows for the differentiation of retinal layers and visualization of microstructures. So, the aim of the study is to explain the visual outcome following retinal detachment surgery based on morphological patterns studied with the help of fundus autofluorescence and optical coherence tomography. The objective include to assess the postoperative visual outcome, to assess the morphological changes in the retina using fundus autofluorescence and optical coherence tomography at 1 week and 1 month postoperative visits, and to correlate the reattachment pattern with the final visual outcome. Study site is a tertiary eye care hospital in North Kerala. Study population: all cases undergoing retinal detachment surgery, either pars plana vitrectomy or scleral buckling or pneumoretinopexy for macula of rhegmatogenous retinal detachments. Study design is a prospective observational study. Time frame: the study is done for a period of 6 months and the sample size is 68 eyes. Inclusion criteria: patients above 18 years of age who are able to give consent, presenting with primary rhegmatogenous retinal detachment, who have undergone pars plana vitrectomy or scleral buckling or pneumoretinopexy. Exclusion criteria include patients having proliferative vitreoretinopathy changes grade B or worse, patients with already pre-existing ocular diseases like glaucoma, diabetic retinopathy, etc., patients with history of previous retinal surgery or resurgeries, high myopes, patients with media opacities, and other postoperative complications impairing vision. Methodology: the enrolled patients underwent a baseline evaluation that include detailed history, best corrected visual acuity using ETDRS chart, dilated fundus examination with 90-degree lens and indirect ophthalmoscopy. These patients were informed about the procedure in detail, and visual acuity, fundus autofluorescence and optical coherence tomography were done at 1 week and 1 month postoperative visits, and the data was collected, tabulated and analyzed. In this study, variables were taken for 0 to 1 month and was calculated using student t-test. Coming to the observation and results: age distribution: majority of the patients were in the age group of 61 to 70 years, 11.4% were above 70 years, and the average age was 57.6 plus or minus 11.7 years, which was consistent with studies by Delomo et al. And Broche et al. Gender distribution: the study showed a male predominance with 68.6% being male. This aligns with the findings of study done by Williamson et al. Duration of the symptom was also studied. The mean duration is 1.3 plus or minus 0.8 weeks with the range from 0.3 to 4 weeks. Previous studies suggest that longer duration of preoperative macular detachments are linked with poor visual outcome. D. Laura et al. Also reported an average symptom to surgery duration of 13.3 plus or minus 4.9 days. Coming to best corrected visual acuity: baseline preoperative best corrected visual acuity in logMAR was 1.885 plus or minus 0.803, and the postoperative visual acuity at 1 week was 1.765 plus or minus 0.611, and at 1 month was 0.918 plus or minus 0.561. This shows a progressive improvement in visual acuity at each follow-ups. Coming to the clinical parameters, all patients had well-attached retina on clinical examination in 1 week and 1 month postoperative visit. And in optical coherence tomography, 21 patients at 1 week had an inner segment, outer segment abnormality in the OCT, who also had poor postoperative visual acuity. Similar to the 1 week postoperative visit, at 1 month also, 18 patients had ISOS abnormalities, who also have poor postoperative visual outcome. Specificity for the comparison was 100 as all patients with ISOS abnormalities had poor visual outcome, but the sensitivity was less. Similarly, positive predictive value was also 100, which indicates that the chance of poor visual outcome in patients with ISOS abnormality is high. At 1 week follow-up in our study, when we compared the preoperative visual acuity with the ISOS abnormalities, it suggested that poor preoperative visual acuity and ISOS abnormalities at 1 week also has a positive correlation. Persistent subretinal fluid also was noticed at 1 week and 1 month visits, and it was also correlating with their best corrected visual acuity. We couldn't find any fundus autofluorescence findings. So the conclusion is, patients who have not attained good postoperative visual outcome after the retinal detachment surgery, there can be microstructural changes, and the most significant change was inner segment, outer segment abnormality, which was correlating with their suboptimal visual acuity of the patient. These are my recommendations. These are my references. Thank you. Thank you, sir.